All right, LPC ethics. So I have a doctorate in counseling, and that's one of the reasons why I was able to be an LPC. And I can put my iPad down. Now we're good to go. So it gives an opportunity for me to use the skills just like you. And people are in different contexts. Some of you are in private practice. Some of you are working with children, adolescents. I'm not trained in either one. So off and on, I get parents who will say, well, you did such a good job with me. Why don't you see my 16-year-old? And I always have to say, I'm really not qualified to do that. And that's part of our ethical standards, is to know when you are qualified to do what you are qualified to do, and not take clients who you may not be, just like a substance misuse in the same way. So many ethics, professional code of conduct, they're on the market. And when I've gone through all of these things myself, and including some of the doctors and nurses, and they're very similar. It is respecting the client, honoring the client, not to cross any kind of boundaries that you would, as a professional, would not. And to me, what we have is very similar to other professionals. So auto mechanics don't have those ethical conducts, right? Car salesmen, they don't have any kind of a conduct that they have to do. But what makes a professional and what makes a professional to be in a position where they are with people who are vulnerable, that makes us be responsible for our actions. That holds us accountable. So if you think really about our association, LPC, they're really looking after the client, not so much as the practitioner. So they're looking out for the community. Their interest is to protect, because they assume you already know. And they assume that you have read the code of conduct and you know the issues. And it is surprising to me. I look at psychologists and ACA and AMA, AAMFT, APC. Would you believe the first, probably the one misconduct that usually happens is some sexual in nature, an inappropriate comment or inappropriate touching, or actually having sex with the client. So especially if you're living in a small town, it is very easily, it spreads. So as much as we know, the first thing we're not supposed to do, it always astounds me whenever I go off and on and look, what was the most frequent violation, including physicians? It is sexual misconduct. And oh, by the way, as some of you may not know this, but I'm also a United Methodist clergy. And that is also in that profession, that is one of the primary misconduct with the clergy. Do you know who are the most ethical professionally, a profession that you know of? Anybody can speak. The number one, and trust me, it's not clergy. I'll give you that much. Anyone? Yes?
Pharmacy.
Nope. Good guess. I'll give one more person a chance, and then I'll tell you who the next one is, who the first one is. Anybody else?
I'm going to say teacher, but I've read a lot of things in the news. And yeah, so even if I was going to say teacher, I would have to retract that due to what we're seeing in the news.
Yeah, thanks, Shannon. Appreciate that. The number one professionally, the number one profession that comes at the top of the list practically every year, if not every year, I don't know how often they do that, it's nursing. Nurses are the most professional and most ethical in their conduct. And I work with them. They are my co-workers. And physicians are also my co-workers. Social workers are my co-workers at the hospital. But they come at the top. And just for your interest, you think clergy might be 3, 4? Try 7. So I get shocked every time I see those statistics. Okay. Somewhere along the way, we are influenced by what is right and what is wrong. And we will get into it, and I would like to have some conversation when we go to a breakout session here. So I'm going to give you some material to look at. What kinds of things, as in your childhood, were you told, that you learned that made you think this is right and this is wrong? This is acceptable and this is not acceptable. This is normal and this is not normal. So many ways that we can look at. So the primary principles of ethics in helping professions is in the United States, we put autonomy as number one. And that's being challenged in all professions, particularly in the medical community. And, we always think about, and this is one of the things that the LPC, I belong to all these different groups. I get PCs mixed up. The LPCs, actually, when I started teaching this, they kind of modified some of the things on this autonomy stuff. And then we'll get into how it is slightly changed a little bit, because United States is not a homogeneous community. We are a multicultural community, and we're beginning to recognize that there are cultural groups and there are ethnic groups, that autonomy is not number one. Especially when you look at some of the Eastern cultures, if you look at even within the United States, some of the African-American communities, it's a decision made by a group, decision made by a son, oldest son, or the husband. And you're talking to the patient, but the son answers all the questions, even though she can speak. So what has a counseling group has done with this? What LPC has done is, let's take that into consideration, and someone might want to bring another person with them to counseling. And that's a big no-no. We always think, oh, it's got to be confidential. I don't know how they're going to interpret what others might hear, but you don't know that anyway. The client, how many times have you had a client come to you and say, you would not believe what the therapist said or did or whatever? And we're in shock. I've been in shock. And one of the examples that I had was, I had a client that came in, a female client, and she said, well, my therapist started calling me and texting me. And I said, so what was wrong with that? My clients text me and say, I can't make this session. Can we schedule another one? And those things are also important to remember. We can text back and forth. Just keep it to what has to do with your meetings, that your counseling sessions. But anything beyond that is crossing the boundaries. And if we don't know that, then that's what makes us the professional. We ought to be able to know what is out of bounds, out of the boundary. So what we want to remember is that autonomy might be important, but we also know there are some cultures, sometimes, they need interpreters. And in West Virginia, rural West Virginia, we've had only maybe a couple of times, 2 times that I know of in 30 some years experience, where I had a father, an older father, who could not understand English, but needed help. And he brought his son, who was a coal miner, and the coal miner was Ukrainian, and they're both Ukrainian. So he had to sit and explain everything that I was saying. But was I sure what he was saying is what I was saying? No. And so then it becomes very important when you do not have just one person in the room, and that person's autonomy is shared by another, and your chart notes become very important. If you put in quotes exactly what the son said, much better than interpreting what the son said. So has anybody had any experience like that? I've only had 2. Okay, so beneficence, do good. That this is very much like what the medical doctors suggest. I'm into all kinds of this Ayurvedic stuff, and take melatonin instead of some kind of sleeping pill. And can I really offer that people take Benadryl, Tylenol PM, and things like that? And can I actually, in the session, while they complain about sleep disorder, can I make a recommendation like that? Is that crossing the boundary? So we want to look at what is working for us, and is this what I'm about to suggest, or I tried this. I think we can always say I tried this, but I can't recommend that for you, because you don't know what other medications that they are on, and that might not help them at all. And so the older I become, the more doctors I have, and the more older I become, the more help I need to live, and trying to do good. With all the good intentions that we may have, we may not be helping other people to connect to what they need to do. So always make a referral. That's something you want to talk to your doctor about. Let them, whoever it is, or pharmacist, because the pharmacist now, they have this, all the medications that you take, they have it in front of them, and they can make a recommendation. So again, this is sticking within our boundaries, so we're not doing something that's outside of our boundaries.
I just have a question on that real quick.
Sure.
Okay, so I know, no recommendations, even on over-the-counter medications or anything, making appropriate referrals and such. Is it okay to offer suggestions as far as natural remedies? And I know that's kind of getting into the same field as medications and not wanting to do any harm and things, but just possibly recommending things like essential oils, or
A good question.
massage therapy, yoga, And not saying, oh, you know, you have to do this and this is my recommendation, but just putting it in the phrase as, have you ever tried this?
Have you ever tried this? That sounds fine. Let me tell you a complaint that went to the board about essential oils. And the reason why I mentioned that is because that is one of those things that has become popular and related things to that. And as the complaint was, there is not enough scientific evidence that says this is the board's decision that was made. There's not enough scientific evidence that provides proof that this is a method that someone can use and benefit from it. And how many of, and there is no licensing either to recommend. There is no overseeing chemical people or whatever the licensing people to offer those kinds of therapies. Now, I have asked, well, have you thought about things that other people have tried? And I have said, this is what I have tried. And the essential oils didn't work for me, but the massage worked for me. And some people are really picky about who they want helped and who they want, what kind of things that they want to try. The only thing that my word of caution here is, oh, my therapist said to try, how they interpret that, that's what worries me.
Right.
It's like, my therapist said to do this. Actually, what you may have said, Tina, is, I have tried this. Maybe you might want to give it a chance. I don't know, but you have to talk to somebody else who knows more about it, but they will interpret it as Tina said, I can go ahead and Tina told me to do this. But some of these essential oils, you know, there are some chemicals that may end up having a reaction to skin reaction, smelling reaction, and I don't want to be any part of that. And you know, the board has already said no. So we can't sell it as part of our, if you're into all that, you can't sell what's, if you have a website that you're selling your essential oils, or in your office, you have that available if people want. No, that's a big no. So again, that goes back to your scope of expertise. Stay within the scope of your expertise. So justice and fairness. I'm sorry, non-malfeasance. Oh my, I said that right away. This the way it's supposed to say. Oh, it's supposed to be pronounced. Avoid causing harm to the client. So how would we know that? Somehow, you know, sometimes you don't know when you cause harm. But if you pick that up in their voice or in their lack of participation, or if there is a way that you can find out, or you have found out this has caused harm, I would be the first one to take responsibility and say, is there something that I said that bothered you, that you want to talk about? So one of the ways that I always begin my session with the client and say, you know, this is our first session, and I don't really expect a second session from you. That's just Ravi Isaiah, that you can practice any way that you want. And people often want to know, how long should I know I'm off the grid here from this page, what you're looking at, and that's just the way my brain works. If it comes in here and it's working, I'm going to share that with you. If there is something that you know that would be helpful for them, let them know that would be helpful. And if there is something that you notice, when I first see the client, I say, there are a couple of things, let me say, if you've never been to therapy. I don't expect a second session, and that would be up to you. I will give you my cell number, office number, and if everything goes well this time, some people click and some people don't click. I put that right out there. And then if it works, I'm going to let you text me back and say, I would like a second session. Because I'm in private practice, that maybe I can do that and other people can't. I'm just giving some things so that you ease the anxiety that they have brought with them, because they may have had a guy who made a pass at them last time. That's why they picked a woman this time. But they're still not sure. Maybe this woman is gay or lesbian, and she might make a pass at me too. Just like that one example that I shared with you earlier, the therapist started texting the client off hours and the weekends, and what her plans were, how she was doing. It was all kind of related to how well she is doing, but it ended up the person being very uncomfortable about it, and that's why she quit and didn't even make us a third or fourth appointment. So at the end of the session, at the beginning of the session, I always say, I'm going to ask a couple of questions. What was helpful? What was not helpful, or what was confusing? Because I want to know if I said something that was misinterpreted. And I'd rather fix it there and then. And so I can say, no, that's not what I meant to say. I meant to say this. I hope that is clear. And then the last thing I say is, you don't have to make an appointment. And then let me know if this has worked out well for you, then we can make another appointment. So hopefully that'll help ease their anxiety if they're coming for the first time. So avoid causing harm to the client. And if you know anything at all, none of us really do that, but somewhere along the way, it's in our code of conduct for a reason. Justice, fairness, and equality. Now, this is where we have a little bit of a gray area. I'm in private practice, so what if somebody says, I went to the counseling centers and different therapists, and I don't have insurance, and they want like $60 or they want $120, and I really can't afford that. Well, I have a full-time job. I could charge somebody $20. And is that fair to the rest of my colleagues? In our code of conduct, for APC, LPC, it's clear that we are supposed to be charging very similar price for each client. And you don't make exceptions just because someone who is unable to pay $60 or $120. And neither do we see a guy who comes in or a gal who comes in with a Mercedes or a Tesla and say, oh, you can afford $250 a session, just like well, I don't know, I think that might be even cheap for a psychiatrist. So being fair, I struggle with that. And so are we just like not supposed to see people who can't afford counseling in a part that the pastoral part of me, the spiritual part of me, the part of me that went into this profession to help people? How can I turn them down? So look around in your area. There are many, I can't say that. There are some institutions, there are some people who, groups that raise money, funds, so that they can subsidize for patients or clients who cannot pay full fee. So that would be part of my professional responsibility for justice. and say, that would be my homework that I'd have to do. Who sees people for cheaper than, if I can only afford $20, who's out there who's doing that? And there is a pastoral counseling center here that does that. So I refer people out to them. Now, if that's not available, then we're really into that gray area. And for me, that's a moral and an ethical dilemma. You might consider, I don't know, I mean, this is gray area, like I'm really emphasizing here. You might say, maybe you might want to go see a life coach therapist. Maybe they'll charge you less because they're not licensed people. So that may be a way to, the part of you that struggles morally, you might consider that. Fidelity, honoring commitments. A lot of times it's the patients, the clients who don't honor the commitment more than the therapist, but that is just part of what we do. So the last thing that I have on this page is, these are pseudo-professional conduct guidelines. Clients don't have to follow, but we do. Also want to say at the same time that we have a pseudo-intimate relationship with our clients. They can be vulnerable. They can share the deepest, darkest secrets, embarrassments, things that they would never tell another person, but we can't join them and say, well, I've done something worse than that. So this is where we talk about the professional boundaries. How do you know when is too much to share? The self-disclosure. We talk about inappropriate self-disclosure. Again, the responsibility is always on the professional, because the client can and might go and tell somebody that you go to church with, or that you know from somewhere else, or just say, hey, you wouldn't believe what Shannon did. She goes to the bar and gets drunk every Friday night after work. So who knows? Or something that you have done in the past. How is that really helping this session for them? And that is a professional judgment that we always want to keep in mind. Okay, did you know, I'm just going to read it because I think this is important and short. The mission of the American Counseling Association is to enhance the quality of life in society by promoting the development of professional counselors, advancing the counseling profession, and using the profession and practice of counseling to promote respect for human dignity and diversity. In light of 2020, all the things that have happened, and I don't have to mention any one of them because all of you lived through that. And the issues of race to political parties. How many of you have lost friends on the Facebook? How many of you have lost your family members? How many of you have cut off conversations and said, we're not going to talk about this anymore? But can we still do that in a way that is respectfully? So then my question here, if anybody wants to answer, they come in and they spend about 10 to 15 minutes of their time putting down one president or the other, which you're the opposite of. Is this become a problem? I'm just going to go ahead and say the names so that somebody was pouncing on Trump and you are a Biden person, or somebody is bad-mouthing Biden and you're a Trump person. And you have to sit there and listen. Any thoughts?
Actually, it's not the political presidential topic that comes up as much as a very rigid stance on vaccinations or mask wearing or not, held personally, whether for political reasons or other reasons. That seems to be the topic that comes up more currently.
Thank you, Dave. That you're right, and that becomes the political. There's political force behind that, and also, yeah, people have actually. I have heard of, not heard of. Actually, my wife is a supervisor. There are churches who have split over masking and not masking. So there's only 20 people in the church, and I'm thinking, what are you going to do? Split in two? Let's just say even half. And now, how are you going to maintain the building and this money that you have to do? So, do you disclose your opinion or your practice to this person when they say, I'm not going to wear a mask? It's not something that I believe in. Somebody was going to say something.
I don't think you can or should, your own opinions there, but it becomes tricky where, especially in a public health crisis, where a part of the mandate relates to public health as opposed to personal belief. You know, your political beliefs about who's in office and stuff, I mean, I don't think you espouse your own political beliefs, but something that's coming up about masking or vaccination becomes tricky for us ethically, because we also have a mandate to protect the public good and health, as well as, you know, aiding our patient. So is not wearing a mask or is not vaccinating or those kinds of things, you're kind of on offensive. Is that a judgment that is in their best interest or not? And that is what becomes tricky, I think, in the current environment.
Very great, good point. We are stuck, and as healthcare workers, in mental health care workers, we do have a responsibility to our community. And in my language, I would say, am I my brother's keeper? Of course I am. And, you know, being a corporate director at CAMC, and I was one of the first ones to get the shot. And I was one of the first ones to, they made us start wearing masks. And I wish I had known that in January. I could have avoided maybe COVID-19, but not this January, last January, before we even heard of COVID-19. So how do you avoid this conversation? How do you have this conversation? And I think it's perfectly fine to say what you just said, which is, you know, I am a healthcare worker, mental health care worker, and part of my responsibility is to look after the society. Look at this thing right here, society, and we are promoting good, respectful conduct and promote that through our profession. So you can do whatever you believe in, but this is my responsibility to do, is to wear my mask when I am in a closed room or in a closed room. How many of you are Zooming most of the time still for sessions? Quite a few. Okay.
Ravi?
Yeah.
A question that's come up in our agency, and honestly, I have an ethical problem with it, is when we all went to telehealth or telephone for sessions, we were already prepared. We had telehealth set up. It was allowable then in meeting the client's needs, but now that we are so far out, the employer is questioning whether or not we can meet client needs because it bills more to be in the home or in the school. And so that's something that's come up recently. Not myself. I have resumed some face-to-face services, but my coworker who has not is getting a lot of flack for this because it's being insinuated that she's not considering client needs when it is an arrangement that they've both agreed upon. So her clients know going in, she's only doing telehealth or telephone. So yeah, that is an ethical concern right now.
So this is a good point, because a lot of times what happens is there's the ACA Code of Conduct and Ethics. And then if you work for an institution, they will have their own set of guidelines and procedures. And that may sometimes not align with yourself. It may not align with ACA, but it has to. That you can always go stricter than ACA, but you can't go more lenient than ACA. And yeah, it does. It has. I didn't realize that it could definitely cause some problems with what if one therapist does it this way and the other one is not. So this is where I hold the administration or whoever writes the policies and to sit together and have a conversation about it and write new guidelines. And that's what we do at the hospital. If something new comes up and we don't know how to deal with it, they pull the right people together and say, we need these voices before we write this policy, because it has to make sense to us. And the policy, when you are most vulnerable, is when you write a policy, the lawyer is going to sue you because you didn't follow the policy that you have already written. And if you don't have a policy, you're much better off. But then the obvious question is, well, it was obvious. Why did you not have a policy? Where's your administration on in a situation such as this needs to have a policy? So yeah, institutions have to pay attention and re-gear and re-meet and rewrite. And we've had to do that. And you know, in therapy, we don't have a lot of new medicines that come and new equipment that comes that causes issues. For us, but in the hospital it does, and that we have to rewrite some things. For example, I think we'll get to this conversation here, and I think I have a case study that we can talk about. That would be interesting. So the ACA endorsed pathway. First of all, they'll say, let me just make sure I got onto the right one. Yeah. Identify the problem, apply I think there was a revision done in 2014, after that 2014. Apply the 2014 ACA Code of Ethics, which means you just have to familiarize. It's very easy. If you just go and look at the title and you can figure out, oh, this is where it's going to be. And determine the nature and the dimensions of the dilemma, whatever the problem might be that has been generated, and generate potential courses of action. Consider potential consequences of each for all parties involved. And this is the pathway that ACA takes and our board will take, and evaluate the selected course of action and implement your course of action. So if we can do that ourselves in our institutions, that'll save a lot of problems and headaches if somebody writes a complaint to the board. And I'll just say it as I'll probably, it's in my slide presentation. Sooner or later, it'll come up anyway. And some of the complaints that we have no authority over at the board. And that is, let's just say, a preacher or what's the word, incense, not just incense, but what's that one word for aromatherapy? Or there are other kinds of therapies that people are using that are not endorsed, that are not studied, that are not, they did not go through the mill in order to substantiate as a science. And they're using that, or preachers, pastors will charge money to do counseling with their parishioners, or other people will come. Well, that kind of, and they do screw up something somewhere along the way, and the client writes to the board. There is no authority that the board has to a pastor or to a life coach therapist who is misconducting or misbehaving. So there is nothing they can do. And I think I have in the past, when I have asked, every year there's one or two complaints that we get about a profession that we can't control because they're not under our board. I just wanted to pass that along. So what I'm figuring is, if I become a life coach therapist, I can charge what I want, and no, I don't have to answer to anybody. I hope there's a bunch of shocked people over there. Yeah, but the part of it is retiring, having all this knowledge and experience, and all of a sudden it's like nobody wants you, and you can't even quote unquote sell yourself. So I am in a way doing some grieving. I went to an earlier class and they were talking about grieving, and I'm thinking, yeah, I'm 62 years old and I'm going to retire here pretty soon from my full-time job. And all of a sudden where's the title? Now I have to take LPC off of my business card. Can't pass that along as part of my thing. So each of us, are somewhere along the way grieving something. Okay, that's another issue. Identifying the problem. How do you go about doing that? Usually there is some kind of a disagreement or misunderstanding. And I think in counseling, what I have experienced is, if you do not catch this thing early on, if you do not sense it, and if there is one thing that I can recall from my training, is we got into this profession because our heart is big and our ears are big, and we want to help people, and we are in that helping profession. And part of that is, let me just ask this question. Are they still making you guys go and do your own therapy before getting licensed?
Well, you have to have so many hours of supervision.
That's different from being in therapy for yourself.
Oh, well, it depends on what program I was in.
Okay.
I am not an LPC, I'm an LCSW. I've been licensed since 1989, and I've always had the in-service trainings. Now, when I was in the PsyD program, you had to get licensing yourself. You had to have therapy yourself. The doctor of psychology program, but not for the LCSW program, unless it's changed now.
Yeah, I haven't kept up with that.
And then the LPC program at Regent, I know a lot of the master level individuals, they just did it. They did participate in therapy for themselves. I don't know if it was required or not.
Psychologists are not required, psychiatrists are not required to be in therapy themselves. So what the point I'm trying to make here is there is a big difference between somebody who has sought help, felt that vulnerability and shared with someone and got help. And some, we don't always click, and I've said that before. Those guys make a better therapist than someone who went to school to get it in here and then apply what they learned. So I always encourage people, if you've never been in therapy, just go be in therapy. I was in therapy when I first met my wife. We had all kinds of issues when we first met in seminary. She's Caucasian white, and I'm Caucasian brown. And her parents or adoptive parents had a lot of problems. And it just kind of forced us to go and say, well, what the heck are we going to do here? How are we going to cope with this? She came to the seminary school and felt like, I don't know any other guy that I'd rather be with than this. And when she went home, it was, how brown is he? They wanted to know, is he really dark Indian or light Indian? Well, when you get into those kinds of situations, you kind of become vulnerable. And I got to be vulnerable and found out what some of the crap that I carried about my childhood and how that was coming into play at this point. And what was it like to be brown in this country for the first time? Understanding at age 14 is when I came to this country. And for the first time, I thought, oh my gosh, it's not good to be brown. It's better to be white. And when you're in India and you're there with 1 billion people, everybody is short as me and brown as me. Actually, we have people who are very light skin with blue eyes and green eyes to very dark skin, but we don't have an afro. Most all Indians have somewhat curly hair or straight hair. So coming here and realizing you're not good enough was a devastating thing that I never shared with my parents, but I was able to share that with my therapist as part of the whole package, and which helped me to be a better therapist. My one supervisor asked me once, he says, Ravi, can you hold someone in your eyes without ever touching them? Can you hold them with your eyes without ever touching them?
Mm-hmm.
Yes,
Mm-hmm.
yes, you can. And you can love somebody without ever touching them. And I'm not saying that love as in our counseling relationship, but in my hospital setting, there are people that I do love that are dying, and they're alone a lot of times. And I jumped in the bed and held on to them while they died. So that was a no-no that I'm not supposed to do, but I could probably get away with that just because of they know who I am and how long I've been there and my reputation. So there are some things that I think as an individual we can identify. There's somebody else coming in. Okay. Identifying the problem is probably, and that's the reason why I'm kind of hoping to tap into your sensitivity so that you would catch it with your eyes, you would catch it with your glands, and identify early on the problem so that we can begin to work on it. One thing that we have found out in the hospital setting, as well as in therapy, the quicker that we admit, like, there's something not right. And that's why I always ask at the end of my session, Was there anything confusing or that made you feel uncomfortable? Because I want to be the first one to fix it. I want them to know I've been watching my language and my gestures and the words that I choose, and I'm not sitting here making a pass. I mean, I've had some of the most beautiful, gorgeous women sitting in front of me, and that I think, geez, oh, Pete, they're really pretty, but I just can't say that. And I can't get distracted by that either. And that takes some, I think, I know I'm getting into some ethical as well as counseling stuff, and that's just the nature of this program. Cleveland Clinic one time put out a video. I don't know how many of you've seen this. It was on YouTube. There's somebody pushing a wheelchair, and the words come out and says, this person just lost their aunt last week. And then there's a doctor and a nurse talking to one another, and there's a little saying that comes out here. She had an abortion a month ago, but they're in a business environment. And so when we think about what is going on with other people, it's important for us to be sensitive to why did they glance that way that they did? I had not caught that before. And I think until we have paid attention to our own issues, and this is what I make a difference between people who've gone to therapy themselves and who have not. And when somebody else catches you and says, so what's going on? That didn't sound like, there's something going on with you. And you didn't even know that because it's an unconscious issue, but somebody else picks it up. And so the earlier we come to understand what we have gone through, identify the problem, let's get this out. People are much more eager to work with us on resolving the issue than if we hem-haw and try to avoid not to bring anything up. So where do I begin? What we're going to do here is I have 2 slides, and then we'll do the case study, and that's when we will take if you want to take a bio break and also discuss with your group, we can do that. When counselors are faced with ethical dilemmas that are difficult to resolve, they are expected to engage in a carefully considered ethical decision-making process, consulting, available resources as needed. First thing that we do if we have supervisors, that's where we want to go. Go to your supervisor. But if you are the supervisor, you find another counseling center supervisor and collaborate with them and say, hey, this is an issue I'm having with one of my clients or one of my therapists. Can you help me to do that? We don't immediately have to go to the board to resolve issues. Find out what your issues are. Like if you've never had any issues, if you had one, where would you go? What's the first course? And this is important because we don't want to go to the wrong person who is not going to be helpful, like our spouses. Maybe they're not LPCs, they may be psychologists or teachers or whatever. But you want another professional opinion rather than another personal friend who's going to give you an opinion. Because we want to stay with the letter of the law, our code of conduct. Resolving an ethical issue is a process, ethical reasoning, including some of the ones that we've talked about earlier, consideration of professional values, and to get to know your code of conduct and ethical principles. And there are primarily usually 4, but people put 5, 6 of them. But I think most all professional groups have very similar, protect the patient, protect the client, and that's our responsibility. And I think that's a pretty big responsibility. Which model is recommended then? Your institution may have their own. If they should have their own. If this problem arises, I mean, you can't always identify 110 problems, but some good general guidelines that say, we're going to do this as step 1, 2, and 3. Use a credible model that can withstand in court. Veterans Administration has a very good one. I mean, excellent. That's why I put that at the top of the top of my list. Veterans Administration, excellent. ACA, APA, AMA, AAMFT, along with your own place of work. If you go to your supervisor or whoever the administrator is, do we have a place that we can go to if there is some problem? How do we start identifying and working with it? I'm gonna stop here and ask if there are any comments or questions, because we're gonna go to case 1, and you will get 15 minutes. And John, if we could get like a 2-minute warning, if the
Sure.
clock could start 2 minutes and say, okay, we need to wind down. 10 minutes is not going to be enough because there's lots of people on the, and not everybody's going to get a chance to share. What I want you to do, there's a reason why I did this the way I've done it several different ways, given several different cases for other people to study, and it really doesn't help. I think if we all look at just one case and take a look at that and come up with, what do we do with this? So anything else before I go here? Are you guys sleeping? I can't tell. I can't see everybody. Am I getting boring?
We're not sleeping.
All right. Excellent. Okay.
Taking notes.
You're not boring.
We're taking notes.
You know, I was
excited
hitting
for
for
the
a
case
compliment, right?
study.
Sorry.
I'm excited for the case studies.
All right. Excellent. This is where I think it's more engaging, because it really gets you to think about some things that may or may not have happened. And what would you do if? Okay. So while you're doing that, I'm going to take a bio break. So I will delete my screen, but I'll be listening. Okay. If we could, John, if you're still there, if we could send people off to, can they still see the screen and be in breakout?
In the breakout rooms?
Yes.
I do not believe so. You are the host now, though.
Okay.
So you should see an option for breakout rooms next to the share screen option.
Next to the screen option. More breakout rooms. Okay. It is assigned and created. So are you all in a room?
Yeah, they're all leaving, which is
Okay,
good.
great. I hope you can see the case and talk about that for 15 minutes. I'll be back in 2.
Jeff, is your internet still down? Okay. Yeah.
Can you all see the case?
I can see,
Sure.
but I got lost somewhere. I lost my group.
Okay.
I
That's
also,
In breakout room 9, we could not see the case.
Okay. You could
I
not see
lost
the case. Okay, let's let me do this. Let me call everybody back in because I wasn't sure. I'm gonna close all rooms. We can talk as a group. Okay, is everybody back in?
I'm back.
Okay.
Yeah.
They're coming in.
I'm back in.
Excellent. We still have about 40 people that need to come up. I think I'm not sure how to share my, I think what I'm gonna do next time is have you guys write this down because I'm not able to share my screen and give you the breakout room at the same time. At least I don't know how to do it. Okay, I think most of the people are in. Can you all hear me? Fine.
Yeah.
Okay.
Yes, I can hear you.
So we have I'm sorry, I wasn't sure exactly how it went. Some people were not able to see the case and some people were not able to hear each other. So I have regrouped and we'll do something different next time that we have.
I screenshotted it with my cell phone and read it to our breakout group.
You're a smart aleck.
Yeah, I did the same thing for our breakout group number 6. So we were able to have a discussion as well.
Excellent. Okay.
We
did
had
the
a cluey.
Thank you for.
We were able to discuss it well, but I wasn't as savvy as taking a screenshot. So that was smart.
Yeah,
thought of
Michael,
that.
he knows what he's doing.
We remembered bits and pieces of it, and then the rest of it we made up.
Okay. Which is okay because life is the way that life is, and nothing's ever exactly the way that it goes. So we have a 32-year-old attractive woman. The reason why I put man or a woman, because we might be attracted to the same-sex person, or we might be attracted to the opposite person. And when we do not acknowledge that, there's our first professional problem. There is our first professional problem. I want to give you an example of my friend who is a therapist. Now he's in Colorado. I think he may be getting ready to retire also. He was in North Carolina and had asked me to come in and do a workshop for their group on Enneagram personality types. And there were about 5, 6, 7, 8 therapists. And a few of them were PhDs, and they had never heard of Enneagram. So I decided to teach that class. And so let's just call him Joe. He said he walked into his office, and then as he was walking through the lobby or whatever, where the receptionist was, there was a very, very attractive woman who was sitting there. And it turns out that he was the only therapist that was next available. And so the receptionist says, I think that's going to be your new client. Do you want me to do the workup? And he hesitated a little bit. So he goes back, he said, wait for a second. I'm going to go talk to my supervisor. An interesting move. So he goes and talks to the supervisor. He said, I am really attracted to this woman. I would rather take her out rather than be her therapist. Okay, so what he actually ends up doing is not accept her as a client, but runs, quote unquote, runs into her and finds eventually that they went on a date. And so is that acceptable behavior? Is there something wrong with that? I know it's not quite related to this, but we're going to get to it.
I don't know if it's necessarily wrong in a sense, but if that person saw the other person that was coming to counseling to, for therapy in their office, then
yeah, there were other therapists available, right?
Right.
So she could have been assigned to anybody, and he could have been the one who was next in line, but there were other people.
Mm-hmm.
So does anybody else see anything wrong with that? It's just kind of a
I
judgment.
don't think your waiting room and your office is a good place to troll for dates.
Definitely
Yeah,
sounds like,
absolutely.
yeah, sounds like using your office as a dating site.
Thanks,
And
Terrence.
the phrase that comes to mind I put in the chat board, but it's the appearance of impropriety at the very least.
So some of the moral problem that I had it with was like, something and she doesn't know,
right.
and you make certain moves to manipulate to a situation to where you're going to ask her out for a date.
Mm-hmm.
Why not just go straight to her and say, hey, I'm Joe. I work here. Would you like to go on a date? That would be a little bit more direct before even all this thing happens with intake. Then make sure that she will never know that he could have been her therapist. And so that's the sticky part for me.
So the other thing I thought of, and I put in the chat, if she's seeing somebody at the agency that he works at, he could potentially have access to her medical records or hear things in consultation about her, and that's not appropriate.
Yes. Or he could always excuse himself if somebody is debriefing her case.
Right. But she may not know that he has that access. You know what I mean?
Yeah.
Unless he discloses it.
Kind of sticky, isn't it?
Mm-hmm.
Mm-hmm.
Yeah, those kinds of things that, we kind of have to go back to our code of conduct. And so let's just talk about this woman who is a man or a woman, 32-year-old, very rich, expensive car when he drives, and is needed to help make a career change, and decides to has a messy breakup with a significant other. And she pays cash, or he pays cash, $200 per session, but you usually charge $150. But because she's rich, she goes, this is what I want to pay. This is what I was used to paying. And gosh, why not take it? Maybe you have a policy in your institution that says we will not accept anything more than 150. Well, then you have to stick with your policy. If you do not have a policy, then you can accept $200 per session. There's no limit as to how much more they can give. Then we'll talk later about gift giving also. The primary work is done, but she wants to continue to see you or he does, just for the sake of keeping tuned up, quote unquote. So what's the identifying problem here?
I think I missed the part where other people pay $150. So that would definitely be a problem right there, but I didn't see that part in the case.
I
It
think
wasn't in there.
he introduced information not in fact or in the vignette.
That's
Yes.
exactly right. I made it up.
Yeah, he has a cluey. Come on, spokesperson for our group.
So anybody can just jump in and say, I'm not really stickler about that.
Yeah, ethically, you can't accept that amount of money. And it has to be fair for all the clients. And then we had the discussion in our group, if somebody wants to chime in, you know, about having the conversation with them about the fact that they've met their goals and sort of processing and terminating with them. However, if they wanted to continue, possibly a referral would have to be made if we found them, you know, so attractive that we felt that we couldn't control ourselves, I guess.
Mm-hmm.
And then too, there could be some dependency issues. Why doesn't she want to let go? Is she experiencing some kind of separation anxiety? You need to process that with her and really see, has she identified and have they worked through all the goals that they've identified? So there's a lot. I think there needs to be, maybe he just needs to help process her and help her cope with this termination process. Excuse me, I used the word wrong. But work towards termination.
So this is where my CBT training has really come in handy. And if you're not familiar with that, please, whenever you get a chance, cognitive behavior therapy is a good thing because they're goal-oriented. And let's just work on what's our homework. One of the things that I do is, okay, you're inviting me as a couple to do what? You want me to work with you. What can you list for me 4 things, 5 things that are most important? And maybe 1 or 2 things that doesn't have to be addressed. So basically when we first start and we say, well, so basically Joe and Julie, we're gonna end the session when we have met these goals. That makes sense, right? So you're bringing something to me and we're gonna work together. And you have invited me in this relationship to fix something that you think is not working. And here are the 5 things that you have identified. And as we go, I will cross them out. And so that's a pretty clear break at the end that says, oh, we came for these 5 things and we finished 5 things, the session's over. Now,
But I think it's important for the client to feel that they've made that success too, not just the therapist feeling like the client has made that success. I think it's important for them to talk together as the therapist feels that the patient has progressed or has been successful in one area, for them to discuss that and to say why, like for the therapist to point out why they thought they've met that goal and get their feedback on it, so that the therapist isn't determining when they move to the next goal, but it's a joint collaboration.
And I would never use the word fix. Never use the word fix. It's to be able to help them and guide them towards finding solutions to their problems. You know, not taking the responsibility for being misfixed. I do that at home, around the house, chores, but not with people.
Thank you for that input. I think both are exactly excellent points. Client is the one who brings the issues, and eventually the client is the one who's going to say, we met the goal. And our job to be being the professionals that we are, and so have we met the goal is one of the questions that we want to ask at the end of the session. Does this satisfy what you came in for? And that's why I always ask, what was helpful, what was not helpful, and did we meet? If I have like 8 minutes or so and say, did we talk about everything that you brought in today? And then this also gives me a chance to, well, one more thing I want to talk about. Well, that sounds like another session. So let's not start digging at this one. So we keep our time, and that's part of that justice thing. Justice to you. You need a bio break. You need a mental break from one set client to the other. So any other comments before I go to what are we supposed to do with this when something like this happens?
I just want to say in our group, we had the kind of consensus that maybe the attractive woman was using the therapist as an emotional rebound, like putting in place of, the significant other that she lost. And it would get to a kind of, sticky situation to where you would have to make a decision that it's detrimental to keep going forward with her therapy if that's the relationship that she wants to pursue. If it's going to be unhealthy for her, then like some other people had said, to make a referral to maybe a community resource for her therapy or something to that effect.
Mm-hmm. And also we want to be aware of transference and countertransference issues here. Because, if you've already determined that this is an attractive man or attractive woman, and how are you unconsciously maintaining that relationship? And are you prolonging this thing? And this is our own internal work that we need to do. This is why I say, that one Cleveland Clinic video that they put out, what they eventually ended up saying is you need to show empathy to your patients. And I just cringed when I heard that, because I'm a therapist and I work with a lot of psychologists and a lot of psychiatrists. There was a psychiatrist sitting next to me while this was being presented at CAMC, and we both looked at each other and we said, that's not right. And whoever CAMC person was presenting to us said, we need to show empathy to our patients and patients. In our case, it would be clients. And the reason why I think, and this psychologist, and I've read only one other article, people get mixed up with those two words. Don't know what the empathy, sympathy means. And here's the distinction that I make. And some of you may disagree with that, and that's fine also, because I have disagreed with empathy and sympathy. But empathy is going into your own psyche, your own feelings, your own experience, and understanding that you have worked through your crap so that you know what gets in the way. Now, if I know my faults. If I see a beautiful woman, I will have a hard time working with her as a client. That doesn't mean I'm not going to, but that's what I need to, that's empathy. Like, can I understand that I have this soft spot for suckers, but people who are poor. I want to take the $20 client and help this 18-year-old out who's struggling, has no parents. But I also need to understand I can't do that. I can sympathize that she's having a hard time with cash. I need to send her to another counseling center and not accept her as a client. Empathy is something that we have done some emotional work, our baggage, our childhood baggage, our last relationship baggage. And here comes this person. And if we have not done that work, we will stumble and we will fall, I think. The best way that I could determine what the difference is between empathy and sympathy is when somebody is drowning, you don't want to jump into the pool. That's empathy. And sympathy is when you are on the shore or on the banks and you throw something at them, and so you can help them pull back. Any comments about that?
It's almost as though you are blending the two.
Right.
And the way you talk about empathy is that you've softened and you're ready to, make a thing with a person. And I can empathize without putting myself in a vulnerable position. I think it's good to empathize. When I think about sympathy, there's a fine line between the two.
Yes, Claudette, I agree with you. That's because you know your stuff. You work with your crap, and you can, when you get in touch with it, you know it, and you can say, I can't cross that boundary. Now, I'll give you an example. I went and talked to a nurse about 2 weeks ago. She is boo-hooing over her lunch and red eyes and swollen eyes. And I said, what happened? I was just walking by and I said, hey, what happened, Julie? And Julie says, my patient died. I said, when did your patient die? 10 days ago. She knew exactly the day he came as a patient. She went home that day and cried because she fell in love with this guy, not as in, romantic, but taking care of him. Her heart went out to him, empathized with him, and then went and talked to her husband about how much she wants to go back and can't wait to be his caretaker. And he lives for a month and a half of COVID, and then he dies. And then 10 days later, she's crying her heart out. And I'm thinking, this woman is not going to last as a nurse for a very long, because it is draining her emotionally when she jumps into the pool. Now, for my own example, there's I had a good relationship with my mom and a bad relationship with my dad. Every time an adult male is loving on his dad and taking care of him and talking about that, I always get jealous and a little bit angry. I said, damn it, he had a good dad. Why didn't I have a good dad? And someone who doesn't care about their mother, who was just laying there, and I'm thinking, geez, I wish I could get in that bed and hold that mom until she died.
I have an opening in my practice for you.
Well, thank you. I only can work till June. I do want to tell you some really an interesting story. I think people learn from stories. All of you guys are highly educated, and some of this stuff really you have to do because you have to do, you're told to do. And to me, people's experiences, I think, will help to catch on. I'll tell you mine. I was 36 years old. I had one baby, and my wife was about the same. She's a year younger than me. And I was beginning therapist. I was working on my doctorate and at the same time practicing. And there came a woman, African-American woman, very attractive. She was in between careers. As you can tell, I've kind of mixed up some of these situations. So I keep those things separate and also help me remember what happened. And as a 36-year-old, I thought I was attractive, and I work out at the gym 6 days a week, 7 days a week, and so this woman has a career change that she wants to make, and kind of smiled awfully a lot in the session, and I kind of
Excuse me.
reciprocated that. And I was smiling too quite a bit. And then one day she comes over and she says, well, I have a proposal for you. And I said, what would that be? And she goes, you know my roommate. And I said, your roommate? She's your other client. And I said, who's the other client? And she named her. And she literally said, we fantasize about you in our bed. Gosh, every week we think about you. We want you in our bed together. This is like giving 2 candies to a little kid. I'm 36 years old, right? So, and I'm thinking, my goodness, this is the kind of stuff when I was a little kid, people wrote in the Hustler magazine or Playboy magazine. I only got those for the articles, right? Yeah, of course. So the first thing that I do with that is, well, let me think about it. I wasn't threatened. I wasn't going to give her a yes. I'm not going to give her a no. But I didn't know how to handle it. This is the first time that ever happened to me. Well, not really. One other happened, but it's a social context. So I go straight to my therapist, my supervisor, and I said, here's what happened. This woman, she's really attracted to me, and so are the other one. How often does a guy get a chance to be with 2 women at the same time and doesn't have to pay? And my supervisor, without blinking an eye, without giving me codes, without saying anything, said the wisest thing. So what if that would happen? Just like that. That gave me permission to explore what was my fantasy without judgment, without making me feel bad already. He wanted me to learn it my way and not tell me what to do. I said, well, okay, I've never been with 2 women. I said, if I am with 2 women, I don't think I could last probably more than 5 minutes. I wouldn't know what to do after 2 minutes. And what else would happen? I would probably be cheating on my wife. I have a child. I am a clergy. I would probably lose my license somehow if this thing gets out.
In that order? In that order?
In that order. I'd lose my wife, maybe not. And my chance of wanting to be a therapist is out the window, and I haven't even started. He goes, oh, okay. The second thing I did was went to my wife and told her. That freed me up to I don't have to have a code of ethics to come to that decision. But I did talk to someone who helped me without judgment and said, you know the rules, and not to do that, you're going to screw up your life and your wife and your family and your licenses, blah, blah, blah. I needed to come to that realization and understanding. So that's my own personal story. Any reactions?
Yeah, interestingly, you made the comment to your supervisor, I've never had this offer before where I wouldn't have to pay anything. But the reality is that you would have had to have paid a lot, but you may have lost everything. So well, I think you're talking about CBT, cognitive behavioral therapy. I think you were not very realistic if you had actually taken that type of proposition from those individuals. So what you would have paid would have been a great deal.
I wouldn't be sitting here today.
You would not have, yeah. No.
You keep talking about beautiful, beauty. Well, in my neighborhood growing up, we always heard that beauty's only skin deep, but ugly is to the bone.
I love that. I've just heard the first part of it. I've never heard the second part. I love that. Love that. Okay.
But can I just share something where
Yes.
we talk about empathic regard? I worked with the Navy for 4 years and I was an incest coordinator. At that time, a service member committing any kind of, or being committed for a sexual offense, they could be retained in the service. And they would have to go through therapy for about a year. And then I would be the one that would read all the therapist reports and things like that to see if the service member was really fulfilling his duties. And then I would have to run a group with the sexual offenders, and they would have their handcuffs on, their ankle shackles on. And that group, but see, I always ask people, why do I feel this way? It's like I have an out of mind, out of body experience every time I work with these men. And I didn't have any ladies, but I always realized in order for me to work with them, at that time, we were being supervised by a psychologist. And I went to the Northwestern training and learned about the plethysmograph and how you make a penis out of this part of your arm and everything. And so one thing I realized is that in order for me to have worked with them, because they really violate, some horrific kinds of violations, things they did to children, I really had to have an appreciation for them and their background, their social, how they looked at the world, their worldview. I had to truly have an empathic regard for them as individuals, where they came from, what they do, where they think, why do they think this way? So that's how I was able to get through that hour and a half with those individuals. And then they would come back next week with the handcuffs, with shackles on, might be a new person. And it was, some of them really committed some very horrific kinds of acts with children.
It goes right through me. I hear those horrible stories.
So that's where empathy. And then after that hour and a half was over with, I would feel okay. I would come back to life again.
And I think that's the kind of, I think a emotional, psychological, and spiritual matured person can access empathy, use it appropriately, and step back out without being compromised. And that's why you just can't throw the word to a bunch of nurses, mental health professionals, and say, show empathy. That's my problem with that. And I think when we have worked with our issues, we know how to access that and not get in the way and help other people out. And so I told you I was 14 years old. That's the first time I realized that it's not good in America to be brown, let alone short, right? You got picked on or got name calling. And so now I have empathy for the transgender people. I have empathy for people who are short. I have empathy people who are overweight. And sometimes they don't get hired for a job. I have empathy so I have been able to transfer that to other people in other situations, because I can reach back in here and remembering how embarrassing that was, how shameful I felt about myself. And at 14 years old, I had no idea who I could talk to. I didn't want to tell mom and dad that. So I know what's that like to hold that secret until I got old enough and mature enough that I was able to talk to what it was like to be African-American in this country, which was worse. And I had good friends that we were able to talk, as well as Caucasian white people and their empathy and their understanding of what it's like. So using that as a tool is a great tool if we have worked it through. Otherwise, it's going to get in trouble with us, or we will get in trouble with it. So,
May I share some chronology?
sorry?
May I share some chronology?
Yes, yes, yes.
I was born colored, right at the height of segregation. I was born colored. I finished high school as a Negro. I finished undergrad as Black. Finished graduate school as African American. So please just call me Claudette.
That's cute.
Yeah.
And
and
that's so
know,
true.
And we can always go back to it and say there's only one race. There are no other races. There is a human race, and that's it.
Can I just add on to?
Yes,
it's
ma'am.
not. I didn't feel like I lost anything or had been discriminated against growing up. My father finished Tuskegee Institute. My mother finished Alabama State University, and she got her master's from Columbia in the 40s, but she could not get her graduate degree in the South because of the color of her skin. And the thing about that's sort of interesting, yes, of course, Blacks are discriminated against here in the United States, but I've had clients from other cultures. So I think people's worldview also and cultural orientation has to be considered, because Filipinos, Puerto Ricans, people from Aruba, they all have this color, they're all color conscious. That the lighter skinned your color is, the more beautiful you are, and that you're discriminated. So I've experienced that from them, from those people, from those cultures, and I was tall and slender at one time, and people would come in and think that I was from their culture, and I said, well, that's why I came to you, because you look like you're from my culture. So people will see in you what they want to see in you. If they like you, they will associate with you to be like them. That's what I've also learned in working with a multicultural group.
Thank you. Some areas do not have the multicultural environment, except for Charleston, West Virginia is one of those things that is in a glass bowl, where there are more multicultural people here than if you go 1 hour outside of Charleston. 1 hour outside of Charleston, Ravi Isaiah is a Black guy. Because if you're not white, you're Black.
Yes, and it used to be that.
What I have learned in the Appalachian culture here.
Yeah, I live in Virginia. It used to be that way here, but now it's a little different. But I did send my daughter to finish in West Virginia University. So we experienced that. I did every parent weekend, and it was very interesting.
Yeah, I think we want to consider that as part of what influence are happening when we have someone that is prejudiced against you, or when you feel prejudice against someone else and you don't want to see them as your client. And that's something that, again, back to the guidelines, there is no reason, ACA does not allow us to turn anybody down. And we have to see everyone. We can't say, well, I don't want to see that person because that's a trans person, or I don't want to see her because she is African American or Aruba person or whatever. So we got to see all the patients. I keep saying patients because I work with patients all the time. Sorry. Counselors, and so the case that I just shared with you here. So where do we go if something like this happens? There is a code, believe it or not. If you just go through period 1, period C, here's the code. Counselors and their clients work jointly in devising counseling plans that offer reasonable promise of success and are consistent with their abilities temperament and development level and circumstances of the client. Counselors and clients regularly review and revise counseling plans to assess their continued viability and effectiveness, respecting clients' freedom of choice. This gives us a developmental and working towards, like, this is work. We're going to work through chapter 1, 2, 3, so that our code says this is what we ought to be doing. So if we ever have any kind of question, just go to the code, and under the headings, you will find, and it's really not a long, not a lot of pages. So you will do okay with that. And it's easy to understand. It's nothing complicated. Okay, I don't know why I put that one in there. Okay, what questions or thoughts at this point would you have? I'm gonna see if I can get my other PowerPoint. It's not letting me do that. Okay, maybe I'll have to click that off. I hope I don't lose you. Okay, any other thoughts?
When we resume at 3:30, will you be the one in charge of, is it C, the continuation?
Yep,
C3?
we just stay.
Oh, we just stay, okay.
I don't want to have to work with a computer again.
Yeah.
That's good. No, I don't. What thought did I have real quickly? Going back to your sample there, the scenario you gave us. I was thinking, if indeed that individual became involved with that person, would he interfere with his friend's diagnosis of that individual? Would there be any, because her symptomatology has been disclosed or might be disclosed by the friend, and would the friend then not be able to objectively diagnose her? I was wondering.
Yeah.
Would there be some interruption there?
Let me just say, because LPC says, our board, that we actually have to have 3 hours in a row without a break. But if we took a break, it's gonna extend. I have to extend the class. So I'm always in a dilemma. Should we just sit through the three hours and get it over with, or take a break? They really don't want us to take a break. That's why I put these case studies, which will give us a break. I'm gonna put this up. It'll give us a break to look at case number 2. And then we will do the same thing. We will go back to look at, so you get your phones ready, right? Or something to write on, because I don't think I can do this again where I leave you guys hanging out.
I'm thanking you now, but I think I leave for another session. So thank you so much.
You're welcome. And we will be here if you're coming back.
Okay.
Hey, Ravi, it's Lisa Westfall. I didn't hear all of what you were just saying about this 3-hour situation, but you know, our class is scheduled for 3 hours. It's just 2 hours, 30-minute break, and then another full hour from 3:30 to 4:30. So I believe we still could take a break right now until 3:30, because we will have our 3 hours in. It doesn't have to be 3 continuous hours.
Okay, tell me, I guess, let me just look. I just don't want to lose this connection, I guess.
Me
That's
either.
what I'm most afraid of.
But then too, is someone else coming in?
We could probably all just turn off our video and mute, you know, and then resume at 3:30. At 3:30, I'm not sure the logistics of that part of it, but just from a number of hours situation, this is allotted for.
Okay, Lisa, thank you very much. That was not very clear to me when I look at the schedule. And because the way that it is written, I didn't know if I'm just supposed to stay right here or come back.
No, I think we're okay. I think
We'll
Could I
see
ask
you.
a question?
Yeah,
I'm sort of afraid of losing the connection too. So what did you say to do to turn off?
so
I'm
what
not
we're
turning
gonna
off
do is
anything.
mute yourself and stop your video.
How do
And
you stop it? See, I'm real ignorant. I'm not very savvy.
if you go to your top or the bottom, like it'll be a little camera. No, right now I'm gonna click it and you're not gonna see me.
Okay.
And unclick it, and then you can see me. And mute button is probably.
Yeah, I know where the mute is. Thank
Okay.
you. Thank you.
And the
You're
bottom's out, the mute, the stop video is also at the bottom.
Hey,
It is.
Lisa,
Yes.
can I have your number in case something happens and I can't get back in? Or John? Is there?
Yeah, I can write it down in the chat.
Okay. That'll be great.
But
And
we
I'm
would be
gonna-
on the same channel because the 3:30 session is C3, so we still be on the third channel.
Perfect. Thank you.
Okay.
That's what I wanted to know.
So that's what I was gonna say. It still should be the same channel because it is still the number 3.
Okay, then we'll say goodbye for now and see you at 3:30.
Okay.
Thank you.
Bye.